Today, I'm Michelle Levander, Director of the USC Center for Health Journalism. Thanks for joining us today for our Health Matters webinar, Medicaid Undone, Covering the Safety Net's New Future, offered thanks to a generous grant from the National Institute for Healthcare Management Foundation. Today couldn't be more of a cliffhanger when it comes to the future of Medicaid and indeed the future of the American healthcare system itself, as the Senate debate enters a climatic moment. Just to recap, yesterday, Senate Majority Leader Mitch McConnell prevailed in his effort to open debate on repealing major elements of the Affordable Care Act. But within hours, Republicans failed to get the votes needed to pass a bill for comprehensive reform. Today, the Senate is poised to take up a version of a bill to repeal most of the Affordable Care Act without a replacement. But even if no bill emerges from Congress in the coming days, it seems inevitable that Medicaid will face massive changes, either through a repeal of Obamacare or changes made on a state-by-state level. Either way, there's a very important story to tell, not just in Washington, but in local communities across the country. Here to explain all this and offer their ideas and expertise are Edwin Park, Vice President for Health Policy at the Center on Budget and Policy Priorities, where he focuses on Medicaid, the Children's Health Insurance Program, and issues related to federal health reform. Kathleen Nolan, a managing principal at Health Management Associates. Previously, she served for 12 years as Director of State Policy and Programs for the National Association of Medicaid Directors and as Division Director of Health for the National Governors Association. And Lauren Saucer, a healthcare editor and reporter at the Post and Courier in Charleston, South Carolina. Her compelling reporting on Medicaid has been singled out for praise by the Columbia Journalism Review. Before we get started, I want to share a few operating procedures. We'll hear first from all our speakers, then we'll open it up to your questions for the final 20 minutes. Because we have several hundred people participating in the webinar, we'll ask you to comment in the question field in your control panel, and we'll read out your questions. If you have technical challenges, please also text us through the question or comment field in your control panel. You can tweet about this webinar at the hashtag MedicaidUndone. We'll also be archiving this webinar at centerforhealthjournalism.org. Edwin, let's start with you. The ground is shifting under our feet as we hold this webinar. What can we expect out of Congress, and how can reporters and policy thinkers understand and interpret this fast developing story?
Thank you very much, Michelle. So I will talk about first what's going on with the Senate bill debate and how it would likely affect Medicaid, including major structural changes to the Medicaid program and to the Affordable Care Act's Medicaid expansion. Now, as Michelle mentioned, yesterday the Senate voted on a 51-50 vote with Vice President Pence breaking the tie to proceed to debate on a bill to repeal the Affordable Care Act. There are effectively going to be votes on three bills. A modified version of the Senate bill, the Better Care Reconciliation Act, which is a repeal and replacement plan, because of procedural problems, including the lack of a Congressional Budget Office estimate of the coverage and cost impact of the bill, including new changes. It required 60 votes, and it went down on a vote of 43 to 57 yesterday. Today, this afternoon, they're going to vote on a bill to repeal without replace, where major provisions of the Affordable Care Act would be eliminated after 2 years. That is also expected to fail. Then there'll be a series of amendments going over the next couple days through the end of Thursday, possibly Friday. But the ultimate result would be a vote on a so-called placeholder bill. It's been reported as a skinny repeal bill, a lowest common denominator bill. It would repeal the individual mandate, the employer mandate, some other provisions like a tax on medical device companies. But really, one should view it as a placeholder bill. Senator Cornyn of Texas, a member of the Senate Republican leadership, has indicated that this placeholder bill is intended to get to conference where they could go back to the same Senate bill, the Better Care Reconciliation Act, and make additional changes in conference during negotiations with the House for an up or down vote in September when Congress comes back after the August recess. So just very quickly to recap, Repeal without replace, as one would expect, would have big increases in the number of uninsured by 2026, a 32 million increase. Premiums would more than double. Many parts of the individual market across the country would virtually collapse with no participation because there would be no replacement after repeal after 2 years. But much of the focus I'll spend is on the Better Care Reconciliation Act, also known as the Senate bill. The latest version of the Senate bill would add 22 million more uninsured by the end of the decade. And a key factor in driving those increases in the number of uninsured are large and growing Medicaid cuts that are included in that bill. The latest version would cut federal Medicaid spending by $756 billion over the next 10 years. That is a cut of 26% by the end of the decade relative to current law. Those cuts are actually bigger than the bill passed by the House, which I'll get to in a moment why that's the case. But these cuts are actually deeper, even though many senators had raised concerns about the Medicaid cuts in the House-passed bill. Now, as a result of these Medicaid cuts, or what's driving these Medicaid cuts, is sharp reductions in Medicaid enrollment over time. By the end of the decade, by 2026, there will be 15 million fewer people enrolled in Medicaid than under current law. And again, that's actually higher than the enrollment declines that are under the House-passed bill. The House-passed bill had a decline of 14 million. So the latest version of the Senate bill actually has a Medicaid enrollment reduction of 1 million more. Now, what are driving these Medicaid cuts, spending cuts, and these Medicaid enrollment cuts? And there's two major changes: the effective end of the Medicaid expansion and the so-called per capita cap. Now, as background, just for a second, I just wanted to talk about how Medicaid financing works today. Under current law, the federal government pays a fixed percentage of states' Medicaid costs. On average, it's 57% for most services and populations. And when Medicaid costs rise in a state, the federal government shares in those higher costs. Similarly, if costs go down, the federal government shares in those savings. The Medicaid expansion has a somewhat higher matching rate, 90% matching rate. So the federal government picks up 90 cents of every dollar spent on the Medicaid expansion population. Now, how does that change under the Senate bill? And it's very similar in the House-passed bill as well. Well, first on the Medicaid expansion, instead of 90% being picked up by the federal government on a permanent basis, the federal government will pay a reduced share over time. So instead of 90% on a permanent basis, it'll be 85% starting in 2021, declining, and eventually going down to the regular matching rate of 57%, which is on average. States' average matching rate, or regular matching rate, goes from anywhere between 50 and about 75%. So this is a reduction in how much the federal government will pay for Medicaid expansion costs in the 31 states and the District of Columbia that have taken it up so far. Now, what would that mean? Well, if the federal government's paying less, that means states have to pay more. In 2021, states would have to pay $6.6 billion more to maintain the expansion. That's going to rise to nearly $43 billion by 2024, 3 to 5 times more than what they're required to pay under current law. Now, in a number of states, 9 states have so-called trigger laws where their Medicaid expansions either automatically or near automatically turn off as a result of a reduction in federal support for the expansion. A 10th state, Alaska, could see the legal authority it used to take up the Medicaid expansion undone under the Senate bill. Now, as a result, that's why CBO finds major declines in Medicaid enrollment as states facing this very large cost shift and the inability of them to raise taxes, cut other parts of the budget, to increase their own spending on the expansion, eventually drop it, in addition to those who would automatically drop it because of the so-called trigger laws I just mentioned. The second part of the major Medicaid changes in both the Senate and House bill is the so-called per capita cap. This per capita cap accounts for 1/4 of the total Medicaid cuts over 10 years under the Senate bill, the latest version of the Senate bill, or an $180 billion cut over 10 years. Now, how does the per capita cap work? As I mentioned, the federal government right now pays a fixed percentage of states' Medicaid costs. Under a per capita cap, the federal government instead would pay only a fixed amount per beneficiary. With that fixed amount set at a level below what would be provided under the current financing system. In general, you look at past spending by states on a per beneficiary basis. That's the so-called base year. And from there, you annually adjust those amounts at a rate slower than expected growth in federal Medicaid costs. Those cuts get larger over time. The growth rate starts out at medical inflation +1, which is slower than expected growth in Medicaid costs, and it's going to go down to regular inflation, which is much slower than Medicaid cost growth looking forward. So as you can see from this slide, just like you have compound interest in a savings account, you'll have compounding cuts over time as the growth rate or the annual adjustment for that fixed amount of money per person is less than expected growth in states' actual Medicaid costs. Now, a Medicaid per capita cap not only shifts cost to states, it also shifts risk to states. So there's an explicit cut from federal funding failing to keep pace with state Medicaid costs. But in addition, if costs go up for other reasons, including a new epidemic, a new breakthrough drug like the recent hepatitis C drugs coming to market, the effects of the aging of the population aren't accounted for in the per capita cap. Population gets older, the baby boom generation becomes older on average. Those who are in their 80s on Medicaid 2.5 times more than younger seniors because they're more likely to need both acute and long-term care. And so as a result, states face not only explicit cuts under the per capita cap, but they also face substantial risks for additional cuts as costs rise faster than expected. These Medicaid cuts from the per capita cap actually grow deeper in coming decades. And as a result, the Congressional Budget Office found that going from that 26% cut I mentioned in 2026, it will rise to 35% by 2036 relative to current law. And that's largely driven by the per capita cap, because starting in 2025, the per capita cap amounts would be grown only at regular inflation. So as healthcare costs rise, as the Congressional Budget Office and others have found, Medicaid funding will fail to keep pace with actual spending needs. The per capita cap cuts grow larger, and as a result, states face even deeper cuts. So according to some estimates, the second 10-year cut, or the cuts in the second decade under the Senate bill, would rise to $2.6 trillion from the $756 billion in that first decade. So very quickly, I will talk about how states are going to respond to these Medicaid cuts, particularly from the per capita cap. Now, Medicaid is already a very efficient program. Medicaid costs less than private insurance. If you enroll someone in employer-based coverage, they would cost more than 20% more. That's largely because of lower provider payments in the Medicaid program. At the same time, the Medicaid provides more comprehensive benefits as well as greater financial protection. Medicaid spending per person has grown historically much slower than private insurance. From 1987, Medicaid per beneficiary spending has grown about 2 percentage points less than private insurance, and there's been an even wider gap since 2007. And Medicaid's administrative costs are much lower, only 5% on average, compared to private insurers, 15% or so. So as a result, states can't do much in the way of offsetting the effects of these Medicaid cuts without harming beneficiaries. The states really have three choices in response to the cost shift to states that they will face under the per capita cap as well as with the expansion. They can either raise taxes dramatically, contribute much more of their own spending to the cost of their Medicaid programs, cut other parts of their budget like education, or cut Medicaid benefits, eligibility, and provider payment rates, harming beneficiaries, either making them uninsured or making them underinsured and going without needed care. So when you look at this, what we're seeing is a big cost shift to states, $250 billion in Medicaid cuts, and as a result, states are going to have to cut people off their Medicaid program, 15 million fewer relative to current law, and those cuts are only going to get more and more severe over the long run, particularly as the population continues to age. So with that, I'll stop, turn it over to our next panelist, but you can see my contact information here as well. Thank you.
Thanks so much, Edwin. Kathleen, regardless of whether we see federal action in this repeal effort, changes are afoot for the nation's safety net. What action can we expect on a state level when the story really shifts to a local story for reporters?
Great question, and I think it really have set us up to turn to that impact at the state level to really say, okay, now we know what the situation is and what their choices are that Edwin laid out. How do we think about this and give it some framework for going forward? But also, I think another important thing is what's been happening in the years since the ACA has been in place. So if we are turning to the safety net more and more, what does that safety net look like, and how is it different from a few years ago? So I'm going to try to flag some issues for our listeners to think about in a state context and to try to look at their own states. So when we look, I'm sorry, I'm having trouble with the slides. There we go. So when we look at the issues of the local decisions, I think Edwin really laid it out. These are the decisions that states will have to make, and they're going to make different decisions and have different types of responses to the program changes that are happening federally. That's true whether the Congress passes something or doesn't, so we're going to spend a little bit of time on that. So the bottom line is states are going to have to implement whatever comes down and make changes to their programs. I'm going to do the same sort of look at specifically the Medicaid expansion and what might happen there. I'm going to look at the capped funding and block grants, but also want to spend just a few minutes of our time looking at what happens if there are not major congressional changes in Medicaid financing or in the Medicaid expansion. Where do states go with this administration and making changes to their program? So as we all know, taking something away from people who have it is always more controversial than giving it to them in the first place. And so expansion states specifically are facing a different set of issues and choices than those that did not expand. There is the exit clause, as I called it, or the trigger clause, as Edwin called it, that there's some level of choice. In some states, they could augment in that period of time when Medicaid expansion federal funding is ebbing away. Others, they simply will have to shut it down from day one. So that's what we're looking at in expansion states, but obviously within the next couple of years, if they take away the federal financing at the expansion level, what would states do? And what are some of the issues that folks need to be tuned into? One of the things that I think is really important is we have a number of health issues that we've been addressing through the Medicaid expansion that could reemerge. Opioids is certainly one that has had a lot of news, but what we've seen in expansion states is the opportunity to provide those individuals treatment and health coverage that could be ebbing away again in the end of the federal support for expansion. Hepatitis C, again, does impact this population. It's an expensive treatment that we've had access to for a few years in expansion states that would go away. I think another important part in expansion states is that as Medicaid has emerged as a solution for childless adults in those states, we've actually seen funding and programming in other areas eroding over this time. Public health programs like family planning or adult vaccinations, we've sort of taken money away from those because Medicaid was covering them more. Mental health in particular is a place where we have seen more and more Medicaid coverage, and therefore we've not invested other public programmatic dollars into those programs. So there's no safety net anymore if you take away Medicaid coverage. And I think another thing that's really important is what has happened in our hospitals and health systems in expansion states. Their ability to absorb uncompensated care or care for those without insurance, they have turned away from finding those resources, from investing in programs to support those without insurance. And if you suddenly have an increase in uninsured, those health systems and hospitals are not yet prepared to deal with that shift back. So what could expansion states do? I think Edwin really covered this, but I really just want to emphasize that it is really a state-by-state decision. Not every state will respond in the same way to a shift of this kind. Some may try to figure out a way to keep some of these adults potentially in the Medicaid program. Are there other opportunities? They do have, in some states, the authority to continue to cover them under Medicaid, even if the federal funding is reduced. So they may look to do that. Maybe it's not all, but some. We might find states that try to do something innovative, like develop state-only insurance products to transition these individuals off of Medicaid into something state-financed. There could be efforts to buy, if exchanges still exist and if subsidies still exist, to help people buy into the exchanges for those that are 100 to 138% of the federal poverty level. Those individuals are eligible in every state for exchanges, although the expansion states obviously currently cover them under Medicaid. Then there may be some more tailored types of responses, and you've seen this in the Senate bills where there's been some investments in opioid treatments. Could you develop some programs for these individuals that really hit on their highest health needs and just put as much state dollars as you can into at least maintaining treatment or coverage of some kind for specific problems that we have in the adult population? And then there's obviously going to be a need to really focus on supporting hospitals and health systems. And really, how do we help them deal with an influx of those who are coming off of the Medicaid program? And then there are the other states, the states that did not expand under the ACA, and where do they turn? What are some of their issues? And I think that if you're in one of these states, and I know Lauren's going to talk from one of these states, where do you go from here if the ACA is dissipated? What are your options here? Your uninsured continue to be a problem. You've already had this problem for this period of time, but what we also see potentially is that the numbers could grow again as people maybe lose exchange coverage, et cetera. And so what we continue to see in non-expansion states, the issue of the uninsured. There are also there were supposed to be some sweeteners for non-expansion states, the reward that was promised politically to help them since they didn't take up the ACA expansion. How are we going to help them? Some of the bills that have been considered divert some funding into non-expansion states. Is that true? Is that not? What does that look like? And how would these states use that funding? What are their options for doing that? And then again, what happens to our healthcare systems and our hospitals? Our rural hospitals in a lot of states are really struggling, particularly in non-expansion states. What happens to them as we go forward? So these are some red flags, some areas to watch in both the expansion and non-expansion states relative to what happens with the ACA. I wanted to spend just a minute on the idea of per capita caps and block grants, less from the details and more from the idea that really emphasizing the impacts that Edwin described on states of a per capita cap, particularly over time, is tremendous, but it varies by state. It is not a uniform impact. Some states might do okay for a few years, then hit a public health emergency or something else, a change in their markets or their systems that could have a dramatic impact from year to year. the level of involvement of legislatures becomes much more dynamic when you're talking about per capita caps and a year-to-year budget at the state level. So I think it's really important to remember a couple of things that I would put in your minds. First is that the impact of per capita caps or block grants is on every state. It's not a question of whether you've expanded under ACA or not. It's every single state that would be impacted by per capita caps. It is dramatic reductions. I thought Edwin's chart is really impactful to understand what it would be over time. That's a serious decline of federal investments at the state level that has to be made up in some way, either through state funds, through cuts in benefits or in populations, in other kinds of props for the safety net system. But I think the other thing that's really important is when we were talking in the previous set of issues around the ACA, we're talking primarily about working-aged adults. In this situation, in per capita caps and block grants, the most likely impacted are typically those of any age with a disability. The reason that's true is they are our most expensive enrollees. If you've got a dramatic reduction in funding, you've got to go to where the money is. And so on this slide, I've just identified a number of impacted populations potentially over time as federal funding is eroding. That includes the frail elderly in nursing homes and community care. We've obviously got disabled adults, those individuals who have severe disabilities of physical or mental health conditions, who don't work and are very poor typically. And then it's also some of the programs that we use to support, for example, individuals with developmental disabilities to live in the community, to find work, to have a quality of life that we've invested in. These are the expensive programs, and these are the populations that could be hardest hit by reductions in Medicaid under per capita caps or block grants. I do think the other thing, again, is this is a state-by-state issue. This is something where essentially every state would work with HHS to figure out what their program, what their cap is on an annual basis, what counts and what doesn't count towards the cap. There's very little information in the legislation about what the cap is and how to calculate it. But if you look across states, it's a mixed bag in terms of its initial implications. It's going to be a yearly negotiation with every state working with their legislature internally, with their governor, trying to come up with their budget, and then working that back with the federal government and dealing with any sort of pop-up issues. I do think that in this, we tend to group per capita cap with block grants. I do think it's worth digging into a little bit if any of these ideas go forward. But the bottom line is per capita caps are just a little bit more responsive to economic shifts and to population shifts than block grants. But there's also the potential for block grants to be more flexible. And so states could sort of have fewer rules potentially under a block grant. And that's really a basic way of understanding the difference. And then I think the really important thing at the state level is that if you have reductions in a program like Medicaid, the state level battles that will exist between Medicaid populations and Medicaid providers fighting for those reduced dollars is a really dynamic and politically difficult situation. And so I think this is something that a lot of states would have, going forward, a lot of challenges every year in coming up with how to meet their financial obligations in the Medicaid program and how to deal with their different populations and providers. I want to spend just a few minutes because I think this is really increasingly the potential for something less than a dramatically sweeping package at the federal level. But it's also important that we understand that there is a whole other side to this conversation, which is what do the Medicaid programs look like in the near term? And this new administration is still sort of getting its feet under it in terms of working with states on things like waivers. And I think to a large extent, people have waited for this to play out at the federal level. But then there are going to be ideas that start to come in that are really relevant to the Medicaid program right now. And so I wanted to just flag some of the signals that have been coming out from HHS and what some of the ideas that are being floated in terms of changes at the state level under waivers typically is how we see these ideas come forward. I've listed a couple that have been surfaced in the past few months by some states. These ideas are adding things like work requirements in order to be eligible or maintain your eligibility for Medicaid. You would have to demonstrate your efforts in work or in looking for work. There are some states that are thinking about drug testing from the sense not so much at this point for eligibility purposes, but for identifying where individuals have a drug problem and potentially getting them into treatment. There are some ideas around eligibility restrictions and waiting periods where if you don't satisfy some of these requirements, you either can't be enrolled or you have to wait 6 months before applying to be re-enrolled if you're off the program, if you're disenrolled. So there's a couple of those kinds of ideas that are floating around. Cost sharing and premiums for individuals within the Medicaid program, as well as the potential for benefit redesign. And by benefit redesign, I mean changes in what is covered and what kinds of programs and services are available to different Medicaid populations. A lot of these ideas are primarily for adults within the Medicaid program, and so a lot of the conversations around these kinds of waivers are happening more in expansion states, particularly conservative expansion states. However, there is some conversations that may extend beyond the non-disabled adults and into other kinds of Medicaid populations. And there are, of course, the opportunities for other kinds of changes, not just the ones that I've listed, but other kinds of waivers and changes in the Medicaid program. And so really it's a question of where do states go from here. I think that overall, I wanted to just leave with a couple of takeaways, and then happy to get to questions when we get there, whatever we're able to answer. But I had three takeaways I wanted to really emphasize. The first is that everything that is being talked about in DC, whether that's at HHS or in the Congress, is going to fall to the states to decide how to respond to either new flexibilities, changes in financing, or other changes in the Medicaid program implemented at the federal level. And that will mean different things in each state. And so it will be really important as you look across and as you watch states respond over the next few years, it will pop up in different places, and hopefully I've given you some framework for thinking about where to look for those ideas. I think that the other thing to think about is that, with the ACA and its implementation over the past few years, there have been some systemic shifts, not just in who is covered in Medicaid, but really the way the healthcare system works. It's much more of an insurance-oriented system than it was in America's safety net before the ACA. We just simply have more people with coverage. And so what happens when we shift back and where are the programs and the orientation if we do have people losing insurance in the way that CBO has said? How do the health systems respond? How do communities respond to people who had insurance who now do not? And it can't go quickly. It will be painful and difficult, and there will be gaps if we do look at a lot of people losing insurance. And so I think that it will be really important to watch the response, not just of states, but of the healthcare system to those issues. And then I think that I flagged there that Medicaid participants are a diverse group and that different changes will affect them differently. And the same is true of states are a diverse group and they will respond differently. And so I think that there's a real need to understand that Medicaid is not a single program. It's not a single delivery system, and there isn't a single kind of person who is a Medicaid recipient. It is widely varied, and any of these conversations could have some very different impacts on how those different populations fare under the Medicaid program going forward, and then also how states fare in any changes that exist at the federal level in terms of what that means for them and how they choose to respond on a state-by-state level. So with that, I'll turn it back over to you, Michelle.
Thank you so much for this nuanced and really excellent overview. We're going to turn to Lauren now. Soon enough, our attention will turn from the high-stakes battle in Washington to understanding the human stories that make all this real. Lauren, what strategies can you recommend to reporters for stories in this time of uncertainty, as well as once we know more?
Sure. Well, like Michelle said, my name is Lauren Author. I work at the Post and Courier in Charleston. We're a relatively small paper in South Carolina, although the largest in the state. And I've been covering this for about 5 years. It's been a 5-year long learning process, and I'm probably going to talk a little bit more basically about the program than Edwin and Kathleen have, but hopefully it'll be helpful for some of y'all. There's another reporter here with me. Her name is Mary Catherine Wildeman, who also covers healthcare. And we write a health section every week, and we also write for Metro every day, mainly lately about healthcare reform in Congress. And there's also a reporter in Washington. Her name's Emma Dumaine, who we hired last year, and she's been invaluable to us. She is our Washington correspondent for the Post and Courier, and I really rely on her every day to figure out what's going on the Hill and to report back what our delegation is doing and planning and what they're saying. All this is just to say that, you know, we're covering healthcare stories across South Carolina pretty comprehensively, but I'm definitely not doing it on my own. We've each sort of carved out areas that we cover on the beat, and mine over the past 5 years has been Medicaid. When I joined the paper, it was very early 2013, and most states around the country were trying to figure out how or if they were going to expand their Medicaid programs. And Edwin and Kathleen have talked a little bit about the Medicaid expansion, but if there are reporters on the call that don't have any background on this, just most of you all will remember there was a 2012 Supreme Court ruling where they decided that the law was constitutional, but that states could not be compelled to expand their Medicaid programs with money under the law that was made available through the law, and South Carolina did not. And at the time that I started, there were, you know, lawmakers and lobbyists and hospital people who were talking a lot about it, and so I was writing a lot about it all the time, it seemed. And my coverage has just evolved from there. Obviously, this is front and center again as Congress is talking about it, but I think our readers have been well served by sort of sticking with the Medicaid story over the years. Anyway, I wanted to start off by saying that I think that for reporters who don't have a lot of experience covering this, there are a few basic stats, no matter what state you live in, that should be included in almost every story that you write. Because, and it's important to acknowledge this for the average newspaper reader, this is so complex. And it, on the surface, might not necessarily be something they think they care about or should care about. But anyway, so first you need to explain enrollment in your state. And this can be accomplished really quickly, no matter what sort of Medicaid story you write about. You can either include it like in the text of the article or sort of a by the numbers box. But I always talk about enrollment. I always say that there are more than 1 million people in South Carolina enrolled. That's about a little less than a quarter of our state population, and that of those 1.1 million people, 660,000 are children and 126,000 of them are disabled. These numbers, I think, are important to regularly point out because there's a lot of negative stereotypes out there in South Carolina, and I imagine in other states too, about who qualifies for Medicaid, and a lot of people don't realize that so many children are enrolled in the program, or that, for example, Medicaid covers most nursing home costs. So I make it a point to include these numbers in almost every story I write. The other big sort of data to include in your story is cost. Medicaid is very expensive. In South Carolina, it costs $7.3 billion, and Edwin was talking about how, you know, average federal funding towards Medicaid programs is about 57%. In South Carolina, it's much higher. It's about 70%. That's what makes some experts in South Carolina, at least, and in other places too, so worried about, you know, what's going to happen in Congress, because we get a lot of money from the federal government for Medicaid, and if that changes, the program here will have to change in big ways too. I like to tell those stories with patience. I feel like that's how I can sort of draw the reader in. If you can put a face and a story with potential with policy, then I think that's a winning combination for at least our readers. A few weeks ago, I'll share one of these stories with you that I recently told. We went up. This is an 11-year-old. Her name's Tamaya McCullough. I went up to Georgetown, South Carolina, which, if you're familiar with the Myrtle Beach area of the state at all, it's about half an hour, 45 minutes south of Myrtle Beach. And she is 11 years old. She has sickle cell disease, and she requires hospitalization about once a month. She's also a pageant winner. As you can see, she was trying on her crown for us in her bedroom. We were up there. And she's used Medicaid her whole life. She's qualified since she's been a baby. That interview with Tamaya evolved into a story about several kids with really serious medical conditions who also need Medicaid and whose parents are also really worried about what's happening at the federal level. One woman told me that Medicaid is how their family survives. It's how they put food on the table, and it's how they pay their mortgage. I mean, otherwise they couldn't afford it. NPR actually ended up picking this story about Tamaya up last week, I think it was. So some of y'all may have heard about her through them. For me, on the ground, finding these patients can be the hardest part. I go about it differently every time. There is not like one sort of plug and play way that I can explain how I find people. Sometimes they find me. I mean, I have written, I can't even tell you how many stories I've written about Medicaid over the past 5 years, but in every article at the bottom, my phone number and email are printed. So I think when people are Googling about South Carolina Medicaid, I think my articles come up. And so they end up reaching out to me, and I've gotten a lot of good stories that way. They also send me, emails, and I get snail mail sometimes. Occasionally, I'll send out, sort of a request through social media. That doesn't work as well as some of the other ways. For this story with Tamaya, an advocate for the local children's hospital helped connect me with her mom. It obviously helps to have sources who can help you find patients on deadline. I think, and this is one of my main sort of pieces of advice here, is to reach out to sources when you're not on deadline. When I first started covering healthcare, I'd have lunch or coffee like with any doctor or hospital executive or policy person who could spare an hour with me. This advocate who helped me find Tamaya, for example, I talk to her regularly. We text, we have lunch, and I rarely call her with questions on deadline, but when I do, I know she'll pick up the phone. This is just basic source building. I guess it's applicable to any beat, really, but I'd recommend finding sort of a policy mentor, someone in healthcare, not necessarily a journalist or an editor, but someone who's really smart, widely read, someone who can give you criticism about your work, but who you can also go to with, complicated questions about how health policy works. I've been covering this for years now and still have questions every single day. I'll talk about one last story before wrapping up. I wrote about this for Columbia Journalism Review last month, and I talk about Jim Connor a lot, probably because I think about Jim Connor a lot. But he called me last year. It was a little over a year ago, and he'd been diagnosed with esophageal cancer, and he'd read some of my Medicaid articles online. I think that's how he found me. And he was really mad. He had filled out a Medicaid. He was uninsured. He'd been diagnosed with cancer. He'd waited months to see a doctor because he couldn't afford one. He filled out a Medicaid application at the local county office, and somehow the office staff had taken his paperwork, but had given it back out to another applicant anyway. All of his personal information had been compromised, and he hadn't qualified for coverage anyway. It's really difficult. Because South Carolina did not expand the program under the ACA. It's really difficult for adults without children here to qualify for the program. Anyway, Jim was at the Medicaid office in tears, and he was frustrated. He had late-stage cancer, and he was uninsured, like I said, and he didn't know what to do. And so this eligibility worker told him that he should go home, he should drink some green tea, and he should research his cancer diagnosis online. So he was mad enough that he called me. I wrote the story. I followed up with another article last spring when the Medicaid agency apologized to him for misposting his application. And then the last article I wrote was after Jim died last fall. A local hospital had been covering his cancer treatment, but through their charity care program, but it was really too late. The cancer was just too far advanced. It's impossible to say that Medicaid would have saved Jim's life, although he certainly would have qualified for a policy if South Carolina had expanded the program. And, I should point out that his story is atypical. Most people in this coverage gap aren't going to die, but you know, I still think it's an important story to tell because it demonstrates what's at stake for some patients. I mean, if Congress cuts, you know, billions and trillions of dollars from Medicaid over the next decade, you know, there will be stories like this in every single state, no matter if it's an expansion state or not. I'm basically finished. The last thing I would say is that for reporters who are just starting out doing this, I would get to know your Medicaid director, at least, you know, have a sit down face to face. That's really helped me over the past 5 years. Another thing that I've also learned is that Medicaid directors cycle through the office fairly quickly. I mean, they stay for 2 years, 4 years or so. So getting to know former Medicaid directors from your state is helpful too, and often they'll speak more candidly than people who are currently holding the office. So here's all my contact information, and I'm obviously happy to answer any questions that y'all have. I hope this has been helpful.
Thank you so much, Lauren. We're going to turn now to everybody's questions. So if you have a question for any or all of our speakers, please go ahead and type it into the question or chat panel on your control panel. We have a few early questions already. One from Rocio Gonzalez, who says, what do cuts to Medicaid mean for counties, their safety net population, and corresponding safety net services? What messages can we use to encourage county administrators to strengthen their safety net services? Anybody want to take on that one?
So this is Kathleen. I'll go ahead and start. You know, I think this is exactly the kind of thing where it will be important to start to prepare if there are changes that are coming in terms of more folks with uninsurance. Yes, counties have been one of the programs that I think to a large extent we've even taken money at the state level to support Medicaid away from counties, and so they would be cash strapped, particularly if there are changes in Medicaid populations. I think that looking at to Lauren's point, looking at where some of your populations are and where they would be and who they would be and what kinds of services they would use, I think would be really critical. One of the things that in some states we have folks who are, as we call them, justice involved, those who are coming out of the criminal justice system. In states that have expanded Medicaid, they have access to care quickly if we can get it to them, and then they have access to things like medications for mental health conditions and other things where counties had to provide that kind of service before. So I do think it's one of those places where the safety net may have been, I won't call it eroding because there was an alternative. There was Medicaid expansion in many states, but there is this issue that we'll have to really look at the safety net in a different way if Medicaid expansion is no more.
Thank you. And we have a question from Darylyn Hudson, who says, can you speak to the state expansion problems for California specifically?
Sure. This is Edwin Park. We've done a paper with estimates of how much each state would have to spend to maintain the Medicaid expansion. So California is not one of the states that has a so-called trigger, but it does have, it will have to pay much more than under current law. It'll have to pay 5 times more because unlike, for example, South Carolina, which has a higher federal matching rate, the regular matching rate in California is only 50%. So the state would go from a 90% support for the federal Medicaid expansion down to 50%. So the state would have to pay much more of the cost of the expansion over time. And you can find this paper on our website by my colleague Matt Broadus, which goes to the specific numbers for that state. But certainly California is one of the biggest states, so you could see the biggest dollar cuts. But I think also it's important to remember, particularly with the per capita cap, is that the state already has some of the lowest spending per beneficiary in the country, in large part because of lower provider payment rates. And as a result, there's very little room for the state to compensate for the federal funding cuts that are potentially going to happen under these repeal bills in Congress, because already has made already has a very efficient program. It's already undertaken a lot of so-called delivery system reforms to improve quality while lowering costs. So it would have no choice but to roll back its Medi-Cal program over time as these cuts get deeper and deeper, were these bills to be enacted into law.
Edwin, I think this is Kathleen. I would just add that I know that California has already had a budget shortfall in Medicaid, and this is just at above and beyond all of that. So I think a lot of states already have gaps between their current appropriations and their budget in Medicaid, because, as we talked about, costs of Medicaid go up every year. So I do think that it is important to remember that it would be on top of what might already be a strained budget system potentially.
And just quickly, I did find the right figure. So by 2024, the state of California would have to spend $12.5 billion more under our estimates to continue its Medicaid expansion, which is covering, I think something like 3 to 4 million people, and obviously that's a huge share of their budget when the state was already constrained.
Great. And we have a question from Maria Aranya, who asks, how would community clinic networks be impacted, especially in rural areas? Are there any provisions to supplement or support their budgets?
Oh, sure. This is Edwin. I just very quickly say that in rural areas, a greater share of the populations on Medicaid, both because of lower average income, less access to employer-sponsored insurance. Therefore, clinics in rural areas, rural hospitals, they have a much greater share of their patient population who rely on Medicaid. That's particularly the case in states that have taken up the Medicaid expansion. Rural areas have seen big increases in coverage, and as a result, providers in those areas have seen big benefits in terms of their operating margins, their less need for uncompensated care. So these major changes to Medicaid that are being contemplated, these major cuts that are on the table, would disproportionately affect rural providers, including rural clinics, that disproportionately serve Medicaid patients in terms of their patient mix and so forth. So certainly there would be a major adverse impact and likely in many cases a disproportionate impact as a result of these changes.
We have a question from Margaret Rosenfeld, who says Indian Health Service beneficiaries who are enrolled in Medicaid and seen at Indian Health Services or tribal facilities benefit from current Medicaid regulations because states are reimbursed at 100% for that care, so there's no state share. Do you know how Medicaid changes may affect this program?
Sure. So this is Edwin. So there was a change in the Senate bill to make clear that Medicaid would still pay for 100% of IHS services, but those are for covered services that are covered under Medicaid. So, and there are also some states that have expanded eligibility for individuals who, Native Americans, Native Alaskans, who rely on IHS facilities and are eligible for IHS services. So as states face these big cost shifts and they start making cuts throughout their Medicaid program as a result, as Kathleen mentioned, it's going to be a state-by-state basis. But if they, for example, they're cutting certain benefits or rolling back eligibility for Medicaid, then American Indians, Native Alaskans who would otherwise get those services covered, would no longer have those covered. So these rollbacks would affect access because they would no longer be able to get access to the same level of Medicaid benefits, or they may not be eligible for Medicaid at all. over time as these cuts get deeper. So that it's more an indirect effect, but certainly there would be a harmful effect. And we actually have a paper by my colleague Jessica Schubel on our website talking about how the American Indian Native Alaskan population would be harmed by the Medicaid proposals that are currently being considered in Congress.
Yeah, Edwin, 100% of nothing is nothing. So if you trim the service out of the Medicaid program overall, it doesn't matter how much the federal compensation is, right? So, so it really does come down to if there are changes in the Medicaid program, they would have the implications for the IHS population. So it does make it, and again, it is state by state. I agree with that.
And a question from Nasim Miller, who says, can you explain a bit more how cuts to Medicaid affect hospitals and whether there's a difference in the amount of impact depending on for-profit or nonprofit status?
So I'll talk a little bit about the issues of how cuts to Medicaid, how they impact hospitals. There are a couple of ways. The first is the most obvious, which is that if you are insured by Medicaid, your hospital bills get covered under the Medicaid program, and if you are not insured, you don't. And so obviously who is covered in Medicaid matters very much for hospitals in terms of whether the individuals have coverage. Beyond that, though, when I think, as Edwin mentioned in his, when you tighten your belt, one of the alternatives for every state is to think about, okay, well, if I want to still cover as many people as I can, the best way to do that with fewer dollars is to cut what I reimburse to the providers for that coverage. So what we would expect to see in changes in the Medicaid program is you either reduce eligibility, which means you take people out of the program, or you reduce what you pay for those individuals to get services. So the potential for rate cuts is high if there are fewer federal dollars. And I think that that's true for any kind of provider, is there could be a serious potential for us to ramp down on how much we pay for that coverage. That would be true for health insurance companies, managed care companies that provide in Medicaid. It's not true for federally qualified health systems because we pay them in a different way, but any other provider, home health aides, nursing homes, hospitals, everybody else could potentially see rate reductions, so that instead of getting, $100 for the visit, you're getting $50. And so I think Edwin's other mention was that, Medicaid is already a pretty efficient program in the sense that we already run a pretty lean program when it comes to provider payments. So reductions there can often make it really challenging for those providers to break even, essentially. I think the rural issue is a slightly different issue, but it's equally as impactful. And I think Edwin's point about the fact that rural facilities, health facilities, often see more Medicaid covered lives typically is really the same for clinics as it is for hospitals.
So I think we have time for a couple more questions here. One for Lauren, which is, what's on your story budget list right now? What can anybody do that would be a local story right now?
Well, we're obviously talking to our delegation in Congress about what their ideas are, and I mean that's the immediate news. I think that for me, I write about the policy side of it more. So I'm kind of waiting to see what they're going to vote on, because it makes it difficult to write stories about how patients are going to be impacted when we don't know what's going to pass. We've certainly written about how there are people who are worried about their nursing home benefits, and there's parents who are worried about coverage for their children, but it's all really speculative at this point. I keep in touch with, my sources, and we're kind of in a holding pattern.
Great, thank you. And I think we have time for one more question from Kay Johnson, who says, maternal child health advocates are very worried that the Centers for Medicare and Medicaid will grant waivers that undermine essential benefits. She says governors in the past have tried to get such relief through block grant proposals. What do you anticipate could be at risk for children with disabilities and other vulnerable populations?
So this is Kathleen. I'll touch on that really quickly, and I'm sure Edwin has some other points. I think that I don't want to get too wonky, but I think to the basic extent is that we really don't know too much about what the flexibilities is, the terminology we use in thinking about what states could do differently. We really don't know what kinds of flexibilities would be offered by the administration under a block grant. There's very little detail about what kinds of changes states could make. And so I think that it is pretty much a wide open field at this point in thinking about what changes might come under a block grant kind of program. There's not a lot of detail available to us or any sort of outlay of a vision about, okay, well, how would a block granted Medicaid program be different? What would be required that states would still need to do, and what would no longer be required? And so I think that from my perspective, there's not a really good sense about really what a block granted Medicaid program would be, and whether, frankly, it would be much different from what we have right now. So I don't know, Edwin, if you had any comments on that.
Yeah, just to make 2 points. That one, if a per capita cap or a block grant, these kind of major restructuring of the Medicaid program are enacted, one would see down the road not only more flexibility being provided through waivers, but attempts by Congress to provide additional flexibility, eliminating certain requirements in terms of benefits or populations under current law, as states clamor to figure out how they can compensate for these federal funding cuts, particularly as these cuts get deeper over time. So that's one thing. The second is that once you have a formula in place under a cap with these annual adjustments, it just takes a few words in a bill to change that and lower those annual adjustments to generate additional savings for other budget priorities. And so these cuts could get even larger than they already are under the bills in the House and Senate. And that in turn would create additional pressure for the kind of flexibility. So states would no longer have to provide so-called EPSDT, which is the comprehensive pediatric benefit that all children are entitled to, which help ensures access for kids with special health care needs. So you would see additional actions down the road legislatively, as well as whatever's done administratively, that could eliminate or weaken some of the existing federal requirements beyond the extensive flexibility that states already are able to exercise.
Well, I think we're going to end with that. And there's certainly a lot of stories about implications that could be done in local markets right now. Just from this webinar, I want to thank all of our panelists. We're going to be archiving this on centerforhealthjournalism.org, and shortly you will be receiving a short survey, which we would ask participants to fill out about the webinar experience, as well as future webinars that would be of interest. Thank you so much.